Tonight's first lecture topic is augmentation of keratinized tissue at dental implant sites, review of techniques and materials. The importance of peri-implant keratinized tissue has been controversial. Some studies have shown that the absence of KT is not related to the quality of plaque control, peri-implant health, and marginal bone loss. However, other scholars have found that lack of KT can lead to increased plaque accumulation, BOP, probing depth, mucosal recession, and even loss of marginal bone. The 2017 World Symposium pointed out that there is still controversy over the minimum size of KT for maintaining peri-implant health and preventing peri-implant disease. Recently, an increasing number of studies have found that the presence of KT may be necessary in specific clinical situations. Clinical approaches to increase KT including apical repositioning flap and APF with autograft or Sinolox collagen matrix. Autolux tissue is considered a golden standard, but efforts have been made to replace autolux tissue with alternative material to reduce patients' morbidity. Dr. Wan Peng graduated from the Capital University of Medical Science, Beijing, with a Bachelor of Dental Science, with a Master of Dental Surgery Perio from the University of Hong Kong. He is a Fellow of the Society of Periodontology Committee, Chinese Dermatological Association, Society of Implant Committee, the Chinese Dermatological Association, and a Fellow of Bethune Spirit Research Association, Oral Medicine. Dr. Wan gave lectures at affiliated Dermatological Hospital of Capital University of Medical Science. May I invite Dr. Wan to come up on the stage, please.
So, good evening, dear colleagues, and it is my great honor to be here and to be invited by the Hong Kong Dental Association, and a special thanks for Johnson, who made it happen. And today I'm going to talk about the augmentation of the keratinized tissue around dental implants. The technique and material will be addressed. Actually, after we place the implant, we probably will see some complications like this, with no KT almost here, and there is a minimum KT because of multiple times infection. There is a no KT later. Then we can see there's almost no bone around the implant. And also the very thin phenotype of the mucosa. Then we can see the shadow of the implant here. And the two lateral incisors, but sorry for the color, it's not that clear. And the thin phenotype sometimes cause recession of the gum. It's happened more than the thick one. And some iatrogenic factors, the doctor didn't place the implant in the right 3D position, so we can see the gingival recession, and also the looking is quite compromised. That one is, I saw one case in my clinic, and this case is from the internet. And loss of inter-implant papilla or interdental and implant papilla is very common also in the aesthetic area. And actually all those problems have some solution. We see some like the P2000 is like a Bible, Imperial. It's a very good journal. They report a lot of approach to deal with that, like KT widening, which is the main role for tonight, and the phenotype modification, and the root coverage of the peri-implant recession, and also the profile augmentation for the aesthetic reason, also easier to have plaque control in some area, and the papilla regeneration as well. So back to the original question. I think for the widening of the keratinized tissue is a kind of peri-implant plastic surgery. It's a it's a very original one for the dental, actually. It's decades years ago. And for this kind of situation, we may consider to have surgery for the patient. And before the surgery, we have to think some point. One is whether the surgery is really indicated. And the second, what's the best time for surgery, the timing of the surgery. And thirdly, the right material for the surgery. And finally, the best technique for the best predictability. I think this one is most important for the dentist, for our reputation. Also, do we have any confidence to charge patient that amount of money for the procedure? So for today's topic, because today we are going to talk about some KT augmentation. So this kind of patient which has no vestibulum. Why? Because the patient previously have a huge GBL procedure. It's a huge augmentation. And this also, they have almost no vestibular, and the mucosa is on top of the crest. And for the back one, the lower one is even more complicated because unlike the maxilla have enough keratinized tissue on the palatal side, but for the mandibular, we have limited resource of the cell. And also for this one, it's almost no keratinized tissue here. So we have a lot of cases like this, very limited keratinized tissue for the later implant. I will show some result of this case. And this one is, we only have one real natural tooth in the upper. And the whole area is augmented. So we have a very shallow vestibular. And a similar tooth is, but on the right side, we have one canine here, and we have almost full dental area. And for the full case, we also have a similar problem. It's previous implants done by other dentists. So the patient without KT easily have some problem. I think we already see a lot of case in patient's mouth. If the patient have a very narrow band of the connective tissue, the patient usually have gingival recession. And also the plaque control is quite difficult. When patient brush teeth, patient may experience some pain when brushing. And afterwards, maybe more plaque accumulation, and also the gingival inflammation, and even the attachment loss, also the bone loss. But if the patient has very good keratinized tissue, like this one, it's an implant, so we have a very good KT, we have a very thick gingival phenotype. So I think most of the time the situation will remain stable. And also the patient have low risk for gingival recession. That controversial issue, which mentioned by Johnson, actually I think now it's become more clear in these 5 years. More and more reports seems support the KT is useful to maintain the peri-implant healthy. Actually, in Europero 10, it's 3 years ago, Rozuki have a very nice summary of the systematic review. The green one is there is some association between the connective tissue present and the implant healthy. The yellow one is some neutral evidence, maybe some association, maybe not. And the red one is no association. So we can see only one. It's a 10 systematic review showed only one systematic review have indicated there is no association by Lisa Mayfield. It's almost 20 years ago. I was shocked at that time. Wow, with no association? I was sure, not kidding. But now a lot of research support there may be some connection. So we have to carefully read that. It is unfair to not mention the gingival phenotype other than the KT volume, because the phenotype also influences the long-term stability of the soft tissue as well. And the study shows the thin phenotype have more gingival recession and also more bone remodeling after the heading cap connection. And they found the thick gingiva will have more remodeling afterwards. Very interesting. And that book is quite nice. The author, they have the serial bone loss, they have the book to elaborate the concept of this. And the thick one will have some advantage. We have less per-implant problem. The implant soft tissue will be stable, and also we have the benefit of the color of the peri-implant tissue, because if the mucosa is more than 2 millimeters, the material underneath the mucosa will be fully covered. You even use metal abutment, it cannot be seen, cannot be noticed. So it's very good. And this finding is also supported by the systematic review and the meta-analysis as well. So for the very good looking and stable implant surrounding soft tissue, we should have KT, which is more than 2 millimeters, and the enough thickness of the mucosa is more than 2 millimeters as well. So it's a 5 years clinical result for the implant, for 1-1. If we have this kind of condition, it's quite easier to get stable long-term effect of the implant. But do we have always find out this kind of situation in the clinically? I don't think so. Maybe in my dream. I can dream maybe 1%, maximum 5% of my patients have this kind of condition, but it's not. What can we do? Probably we do some hard tissue augmentation, soft tissue augmentation, then the situation become more or less like this. And it can give us better stability of the peri-implant tissue. And with a very good peri-implant soft tissue, we probably have a better biological seal. It means the curve around the implant is really strong and stable. And we could have improved plaque control because there's no pain when we do the oral hygiene, when the patient do the oral hygiene. And if the oral hygiene is good, we can suppose the inflammation is less, is it? As a perio guy. And also the stability of the hard tissue and soft tissue as well. And also this one is quite important, soft tissue profile. Why? One is aesthetic, no doubt. The patient will have better aesthetic with good soft tissue profile. Another one is it will facilitate patient to have better plaque control as well. I think for the most important thing for the perio is patient communication and patient compliance. If the patient can do very good plaque control at home, I think everything will be fine. No big deal happen. But if even you do a very good job, if the patient cannot brush, it's useless. After 5 years, the patient will come to you with an implant in hand. Yep. I have those situations before. And after, so we have now we have a lot of reason for the peri-implant tissue modification. So where is the right time for that? Actually, the surgery can be done in almost every step of the implant. Like before the implant, before the implantation, this case, the 1.5 is definitely hopeless. It's mobility 3 and attachment lost to the apex of the roots. And there's a huge defect around here. So later, maybe after extraction, we may do the vertical augmentation to get enough bone to place the implant. But with this kind of soft tissue, I think it's quite difficult to do any complicated surgery later. So we have to make the thing easier to handle. I put a soft virginal graft to seal the hole. Yep. And after a couple of weeks, the site heals well. At least the soft tissue looks well, looks good. And I think for that situation, it's ready for the complicated surgery. And during the implantation, we can also do something to change the soft tissue. Like this, I seldom do the immediate implant. I think I only have less than 20 cases with immediate implant. And most of them are on the bicuspid area and premolar area. I have less than 10 cases on the anterior. I think it's a little bit dangerous for me if I cannot handle everything very well. So for this case, I think it's a good candidate for the immediate implant. After place the implant in the right 3D position, I put some bone chips, bone grafting into the gap between the implant and the bone plate. And afterwards, I took a CT graft to augment the labial side of the implant. And the suture to seal, I use the CT graft to seal the hole, seal the extraction hole. And after 4 months, everything healed well, and I reopened the site and do the tissue molding, and afterwards I make a final crown for the implant. It looks quite okay. And 10 years later, everything stays there, except this one. This patient is a very good drinker. Every time I saw him, he always drunk. Every time, even for the surgery session, it's like, oh, something like that. He's a very funny guy. And he moved from Beijing to Chengdu. And you know, the Chengdu is the best entertainment city in the whole China. Oh, there's a lot of activities after the dinner, and KTV, and drinking, a lot of things. And at that time, he drink a lot, and he got drunk, and he poor guy, fall on the street. And you see the veneer of the lateral incisor was broken. And I didn't see him for 10 years because traveling around China, and he was a very good player, I think. Yeah. But one night saw him, the veneer has been broken. Then I said it's okay. If you have time, I will change to another new one, and he disappeared again. And even after the implant placement, I think that time point is most favorable time for the KT augmentation, because we know how much KT left for the implant. For this case, only a very, very narrow band of the KT. It's around 1 millimeter something. So for this kind of case, it was 15 years ago, I think. At that time, I just a beginner for the KT augmentation. So I divided the surgical to two steps. One is at the volume of the KT, widening the KT, and in the second surgery, I will exposure the implant. So at that time, I prepared the recipient bed, and I take FGG from the palatal side and suture it tightly, and after 2 weeks, it looks survival. And after delivery, the final crown, it looks good. Yeah. But finally, that one recede quite a lot. I think 2 millimeter. I didn't show you the later picture, but it's a reality. And this patient is also a periodontal sensitive patient. It's a perio patient, and actually I did implant for her. It's graduated from Hong Kong Chinese University. I used to be a PhD student there. And she is, at first, her compliance is not that good. And after I delivered the final prosthesis, after 7 years, the patient came back to me, and with swelling area on here. Before it's okay, before I finish it's okay, but now it's quite a deep pocket around the implant. Also, there is almost no KT here. And that patient is not done by me. The implant is done by the university. And the similar thing is the patient have no KT here. So the side with 4 millimeter bleeding pocket, and the patient cannot brush area improperly, because when he brushed the teeth, it was painful. And later I did the original graft. And the graft is really ugly afterwards, but it's protective. And for the material, we will discuss. First of all, is alternate soft tissue graft. We are very familiar with this kind of graft. It's a gold standard even now. It's FGG, it's CTG. And we have a lot of evidence for that. And secondly, I think from 15 years ago, the people start to use biomaterial to replace the alternate graft, like synergetic collagen matrix. So I can't give the name. So as I just find a picture for the collagen. And the study shows the collagen can increase the KT, and also the alveolar reconstruction. I think it's quite difficult for the collagen. And the root coverage, it's also quite difficult for the collagen matrix. I don't know whether this result can last longer, but I think mean of the study, the result is 1 to 2 years. They didn't report long-time results. So I think the long-term result will be interesting, but they don't have. And the third material we can use is alloderm. It's allograft from dead people, but I seldom use that. Most of the reason is because of the patient. If the ICOT patient is dead people's skin, and nobody like it. And also the dead people's skin can do a lot of things, like increase the KT-West, like the reconstruction, and also the root coverage. But the healing is more or less, it's a tricky healing for this kind of material. For the alternate material, like FGG and subepithelium connective tissue graft, they took from different level of the palatal mucosa, mainly. The FGG is the full thickness of the keratinized tissue and the part of the connective tissue graft. So it's basically it's between 0.8 to 1.2 millimeter thickness of this kind of graft. And subepithelium connective graft is will be took from here to the fat tissue, something like that. It can be very thick, but I think I'm not lucky enough. I never see very thick one almost in my career. I think the thickest one was maybe 4 millimeters something, never thicker than that. But I did met the tissue is less than 2 millimeter. The palatal side, donor side is less than 2 millimeter. I think I only can take FGG from there. It's quite difficult to take any connective graft. And different alternative material have different application. For the free graft, primarily we can do the connective tissue augmentation around the teeth implant, and also increasing the vestibulum depth. I think it's very, it's not that common now. Before, the people wear denture. If there's no vestibulum, the country will not stable. But now the people didn't use that much denture. So that application is much less now. And also for the root coverage and regional augmentation, but for the root coverage, sometimes the result is unpleasant because the color mismatching. So the color is very different from the surrounding connected keratinized tissue. And for this connective tissue graft, They mainly use on the root coverage, periimplant tissue, tissue thickness augmentation, and for the immediate implant, like the case I showed before, and periimplant soft tissue deficiency. Sometimes we can see that with very thin phenotype. And the rear augmentation is to change the ridge profile. That one is if the patient is quite concerned about aesthetics, we may use this approach. And there is two systematic review by the same author give us some ideas about the KT augmentation. They find on the maxillary area, we probably use apically repositioned flap is enough for the keratinized tissue augmentation. But for the mandible, we can use, because the KT is very limited in the mandible, so we change to other approach like the apical reposition plus FGG or collagen matrix, or even sometimes CTG. And that clinical trial gave us a very good sample. They compared to three clinical approach. One is apically repositioned flap only alone. The second one, the FGG plus this one. And the third one is collagen matrix plus apical repositioned flap. So they gave us three choices. And they found, from the picture, we already see the first one, the apically repositioned flap, we only get a quite limited amount of the keratinized tissue. It's more or less like a scar tissue rather than KT. But for the second one, the apical repositioned flap plus FGG, we see a lot of keratinized tissue later. But the problem is, if for the non-exotic area, it's fine. But for the anterior tooth, the color and the texture is a disaster. It looks very ugly, and it's very different from other surrounding tissue. And for the apical repositioned flap plus collagen matrix, the result is amazing in this picture, in this study, but I'm not sure. I don't know. But from here, it's good. But for the looking, the first one, the third one is good. The second one is not that nice. But the stability of the flap, the second one is good. The shrinkage of the flap is less on the FGG group. Okay, and now I will introduce the apically repositioned flap. It's a very, very old technique, but I think it's the most underestimated technique in implantology in terms of adding KT volume. It's the original one. It's developed by Friedman. It was a long time ago, 1957. Yeah, I think how many doctors elder than that? Is there any? No? Good. And they, for the surgery, they just do a partial thickness flap from the margin of the KT and fix it in the desired position. But you see the result. Is that KT? I'm not sure. It looks like scar tissue. It's ugly, and the band of KT is just minimally increased. Then later, Canio and Miller developed another modified approach. They cut from the KT area, and they do two vertical release here, and they reposition the flap apical to the area, and they definitely get more KT than the previous one, and it looks almost normal, no problem. But in somewhere like here, we still can see some mucosa intrusion into the KT. And for now, the best technique is this one, I think. The Canio developed another one, 2006. So the entire incision is a single incision technique. The entire incision is within the KT area, and they do after the incision, they do the partial thickness flap, and they leave the periosteum exposure, and after heal, the exposure area is covered by KT, only KT. So it's quite nice, the result is quite nice. We see before the KT is only maybe 2 to 3 millimeter. Afterwards, it's quite wide now. It's 6 millimeter something. It's very nice, and also it looks really nice. It's just like a natural one, no scar. So I start to use this kind of technique on the maxillar area. It's an old lady who received major GBR surgery with, at that time, with cytoblast, non-resorbable membrane, a lot of bone grafting. So afterwards, we can see no vesiculum, and also the mucosa is on the top of the crest. So I decided to do the apically repositioned flap to add the width of the KT on the buccal side. So at that time I removed the non-resorbable membrane, and I changed to the healing cap on the implant, and I fixed the apically represented flap on the buccal side of the healing cap. And afterwards, it was quite nice. It's 1 year later after loading, and that one is 9 years later after loading. We see quite natural symmetry KT, and also we see the maturation of the tissue. It looks very rounded and looks smooth. And for the bottom tooth, for the mandible tooth, it's quite similar, but we have less results of the connective tissue, so keratinized tissue. So I have to, for this case, I have to use apically represented flap on both sides, on buccal and the lingual side, and I can gain quite amount of the KT, like this. I do an incision in the mid of the residual KT, and I did the both partial thickness flap on both sides, buccal and lingual, and I exposure the healing cap closure screw. And before I change to the healing cap, I fix the flap by anchor suture. And after change to the healing cap, I add more suture to fix everything. So after I remove suture 2 weeks later, surprisingly, we see the KT grows very well. And after 6 weeks, it looks good, but it's very thin. The problem is this kind of technique generates very thin KT. And this is, I cement the bridge, the day I cement the bridge. It is 3 years later, so the KT remains stable, and also the mucogingival junction remains the same level. Before, I remember there are some papers mentioned about the shifting of the mucogingival junction after we do this kind of surgery. But in my case, I didn't see much. It's maybe 1 to 2 cases with a minimum shifting of the mucogingival junction. So this kind of surgery, I think it's quite predictable result. And for the FGG, I think it is the most common approach we used in daily practice. I have one case which is very similar to this one. So I use that case, but that case is quite lousy. You will see. For this case, it's actually, if I do it now, I will do it, I will change the closure screw to the helium implant as the same surgery. But at that time, I do the KT augmentation first. Then later, I change the cap. So I remove the mucosa, which cover the ridge. And I took the FGG from the palatal side, and I try whether it fit, and fix the graft by sutures. But you see how lousy it is. But it's formed, but it looks ugly. But luckily, the result is okay. I gained some KT, and afterwards, the buccal KT is more than 3 meters at the time, and it's quite stable later after the implant loading. And for this kind of case, it was quite difficult because the volume of the KT missing is huge. And this one, I already placed 4 implants for the bar retained overdenture. And for the patient, I just cut from here. I preserved all the KT for the lingual side, because for the buccal side, I will use the alternate material. And I was lucky because the patient, for the upper maxillary implantation, I do some bone-sectomy to remove some bone, and there is quite a big piece of the KT can be harvested afterwards. So I just harvest a very big size, very big piece, and I sutured, fixed the big piece by suturing like this, by the horizontal matrix suture formally, and the healing is quite nice. Then for the long term, this old lady already have the denture for 6 years. Now it's quite nice. It's good. And also, sometimes we have a quite complicated case like this. The patient only have one tooth on the upper area, canine. And I have done a quite difficult GBR on the maxillary area. So the second stage, I want to have more KT on the buccal side, so I do the apically repositioned flap, and I don't want to have connective tissue exposure on this area, so I took two big pieces of the FGG from the palatal side, and that one is the patient whose palatal size, the mucosa is less than 2 millimeter. So after I took the FGG, it's almost touched the bone. So it's nothing left almost. So, and the patient is was really painful after the surgery for 2 weeks. Then after 2 weeks, it's painful, not really painful, another 2 weeks. And after that 2 weeks, the patient felt very sensitivity. And it's lasting a month. So almost 2 months, the patient back to normal. So it's so sometimes you have pay for the price for the alternative bone graft, alternative soft tissue graft, and it's not good for patient. But that old man is really tough. It's really tough. He quit smoking. Before he smoked 3 packs every day for more than 40 years. And for the implant, he did quit. So it's a really tough man. And it looks okay afterwards. And I noticed there is after healing, there is not much mismatched color. The color just looks normal. It blend with surrounding tissue is quite interesting. I have another case, is similar. The patient was heavy smoker, is heavy smoker, even now he smoke. And he's a very funny guy, he's a friend of my boss. And he, at that time, I told her, if you don't quit smoke, I won't take the consequence. You will take the consequence by yourself. And we signed agreement for that. And he continued to smoke, but he stopped 3 days before the surgery, and during the healing period, he said he didn't smoke. This is after the major GBR. So when I remove it's a non-resorbable membrane as well. Before this one is out of the bone, but now it's surrounded by the new formed bone. And we all know for the non-resorbable membrane, the interface of the bone will be covered by very rigid connective tissue, like tissue. I don't know what it is, like maybe something like the periosteum. And at that time, I took a quite big FGG and fixed it by suture on the top of the crest. And after, I think it's 1 month or 1.5 months, the gum healing well. There's the color looks nice, looks matched. And after the tissue molding is ready for the final processes. And it's a final processes, it looks okay. And also, but we can see some irregularity of the tissue texture, but the color is okay. And it's after 5 years, it's still stable. So we already mentioned about some complication of the free gingival graft. The most irritating one, common one is pain, I guess. But Zucchelli, the god of the plastic surgery, said they have almost no patient have pain afterwards. Oh, so the god is the god. I have no right to question. He said the size and the depth of the tissue, the FGG is really important, it really matters. So the size is not that big, it should be less than 14, width is less than 14 millimeter, and the height is less than 4 millimeter, and the thick of the tissue should be less than 2 millimeter. But for like that old gentleman, the total palatal tissue thickness is less than 2 millimeters. So how can I take physical graft without pain afterwards? It's impossible. But I don't know, maybe the Caucasian have a thicker palatal tissue. I don't know. Prof. Liang maybe have some comment about that. But for Chinese, I seldom see very thick tissue. So afterwards, the Zucchelli said they have less pain, and they can use something like hyaluronic gel and PRF to protect the wound, and the pain will be reduced. But it confirmed by other papers, but they said PRF and HA gel may have some effect. Others have no effect, like palatal stent have no effect. So the pain control is quite difficult for patient. And in this study, they demonstrate the healing process of the donor side. It is the day at the surgery. It was 1 week later. It was 2 weeks later. It was 1 month later. But even at that stage, I think probably maybe half of my patients feel very sensitive to hot water and to mechanical stimulation afterwards. So I always tell patients not drink alcohol, not drink spicy food, not drink hot water or soup, and don't try to eat hot food on this side. Maybe better. Maybe. And another complication of the FGG is shrinkage of the graft. This is one of my patients. It's also after GBR. We see the irregularity of the tissue after the surgery. And I think I need some vaginal graft. So I took a long piece and fixed by suture. It looks okay. It's at least 4 millimeters something here. And after healing, it's become 1.5, maximum 2 millimeter. And fortunately, the patient used the attachment, so it's not a big deal. The patient can clean it very well. And after now it's after 7 years, still okay. There's no peri-implant infection. And the research found that the FGG shrinkage is about 30% in average for during the healing process. And also the reason for that, the paper reports 3 main reasons. One is improper preparation of the recipient size. Another one is a wrong grafting size and thickness. I think for that case, probably I got the third one. It's a poor adaptation to the recipient bed. So probably something wrong with my technique at that time. And another painful experience is bleeding for me. Yeah, especially when you have a situation like this, because for the shallow palatal size. If we took big graft, FGG graft or CTG, we have great chance to touch the artery, the greater palatine artery. So, you know, Xiao Xiao, Deng Xiao Xiao is my sister in Beijing. One time, I did the surgery at the morning. Afterwards, it was fine. It was no bleeding for the patient after I took it's CTG at that time. Phrygian graft. And in the afternoon, I think it's almost finished the clinical session because I have left already. I have something to do that afternoon, so I left earlier. I left maybe 2 to 3 o'clock. Then the patient came back with a lot of bleeding. And Dr. Dong kindly treated the patient for me to put some sutures to stop the bleeding. So the most effective way is put lactation on the artery to reduce the bleeding or stop the bleeding. And you can, but normally I will injection more than the pressure of the pressure of the anesthesia will stop the bleeding, most likely. And another mistake I will never made later is I use the FGG on the aesthetic area. It's my case. It was 12 years ago, I guess. The patient is really difficult. It's a vertical augmentation case with titanium mesh. Afterwards, you see, after the very difficult GBR procedure, there's no KT at all on the natural tooth. So I put some FGG on that to compensate it. Here. The healing looks not too bad, but afterwards, it's 1 year afterwards, we see the color. It's awful. And fortunately, the patient have a very long lip, so it's fine. The smile line is really low. So I was lucky. And it's a male patient, so it's not that aesthetic concern. And it's 10 years afterwards. It didn't change at all. So if you use FGG on the aesthetic area, be careful. And it is not fair to mention, not to mention the strip technique is quite popular, I guess, for the major augmentation procedure, after the major augmentation procedure. It's a clinical report 2 years ago. Afterwards, the doctor used the strip technique. The strip was here. It looks quite nice, fixed very well. But afterwards, it's become really ugly. But we may think the operator is not that good. But we know another God is a very good clinician to do the optical augmentation. It's Urban. They published paper, also use the strip technique. And he was very smart to use a contralateral side to take the strip. And he fixed the strip on the recipient side. Yep, here. And afterwards, it looks okay when the stripper was removed. But we can still see the irregularity of the tissue, the texture. The color is better, it's quite matched, but we see the texture of the tissue is not good at all. So the strip technique is good. I have no idea. I have no right to judge that. Okay, so the FGG part is finished. We start the apical reposition flap plus collagen matrix. It's the very first randomized clinical trial for that. It's done by Sands. It's 16 years ago. And the results was amazing to me. And the patient had a very limited narrow band of the KT, and he just to the original apically repositioned flap, and he sutured the collagen matrix on the area on the receiving side. Yep. And the result was amazing. It's too nice. It's amazing. But I don't know, I have no hand for that. Just normal people. So the God hand helped lead the result, I guess. So this is my case for the apically repositioned flap plus collagen matrix. The patient have a very limited band of the connected right tissue. And at that time, I do the rectal incision on the middle of the rest KT, and I do the split technique, and I put the band of the KT with a flap, and I reposition the flap to the desired position and fix it by matrix suture. And in the exposure periosteum area, I put some collagen matrix on top and fix it by sutures, by a horizontal matrix suture. And after a couple of weeks, I guess it's 6 weeks, the KT is changed a lot, increased a lot. And at that time, I think, why not I take some biopsy? So I use punch to take 2 biopsies, one here and one here. And I connect to the healing abutment. And afterwards, the healing is quite nice. And we can even see some height of the interdental papilla, inter-implant papilla. So it's very strange for me. But the result is really good, and the KT, the rest of the KT from 1 to 2 millimeter to 8 to 9 millimeter, and the patient have no pain during the healing because it's covered. The wound is covered by the collagen matrix, and no secondary surgery site. And at that time I asked Prof. Liang to do a biopsy. Professor Liang did a very nice job, and it confirmed the maturation of the epithelium. And we plan to have a paper. Yeah, I will try my best later. And okay, yep. Oh. And that case is already more than 3 years. The result was quite stable. There's another case. Also, they have a quite narrow keratinized tissue. So I have done a similar technique. The incision is in the middle of the crest, and I did a partial thickness, and to the desired position I want, I fix the flap by suturing, and for the exposure periosteum, I use collagen matrix to cover, and fix the matrix by suturing. And 2 weeks later, we already find the KT increase a lot. It's getting mature. And after, because for this patient, I missed some picture during the healing time. I think my nurse, my assistant, delete the picture. And it's a final prosthesis connection, and it's half a year later. So we see the maturation of the keratinized tissue, and also the mucogingival junction remains unchanged. So it's quite, for very short term, it's quite predictable, quite stable. And also there's a case for the upper one. I did the similar technique, but I just use the one side. And I changed the carbon screw to the healing cap, and I fix the flap with the sutures. And for the exposure periosteum, I cover the area by the collagen matrix. And in 2 weeks, it seems start to heal. Then the width of the keratinized tissue is quite nice. It's 4 weeks. And 6 weeks, it looks very mature. It looks quite nice. And it's thicker, I think it's thick. Then the apical reposition no flap again along. So it's very strange finding. And this is after the final prosthesis. And for the full case, we still can use that. I use the apical reposition flap plus the collagen. And it's healed well. I have a lot of KT here, but I have no KT here. Why? Because there's no cell of the keratinized tissue. So I missed this part. But it's okay. For the puncting area, it's okay. But for the implant area, we have more than enough KT width. It's my only 014 design. I have 4 implants, one here, one here, one here, one here. It's a cross-hatch bridge. It's quite stable. It's already 5 years. So I would like to have a little summary for that. For the KT augmentation, actually more and more evidence suggests that KTYS will influence the healthy and the stability of the implant mucosa. And we can use 3 surgical techniques to increase the KT width. Although the autonomous graft remain the gold standard, but I don't know. Maybe later the gold standard will change. And for the exotic, the apical reposition flap and plus the collagen matrix demonstrate a better exotic outcomes. And in my personal experience, I found if you use collagen matrix, you may have thicker KT tissue later. But I think if somebody is interested on that, they probably do some research on that. I have no right to do research because I'm just a clinician. I have no I have no connection with academic. Okay, and also the apical reposition flap plus collagen matrix will benefit the patient, give patient less painful surgical experience as well. We still have time. Okay. because Johnson tell me maybe I can share some experience on saving the hopelessness. I think the real definition of the hopeless is very complicated. Some people maybe may think this kind of situation is hopeless. I think it's savable. So I add some case which is a severely periodontal involved patient. I want to give you some new therapeutic choice. Like this one, this patient was referred by my colleague, my orthodontist, one of my orthodontists. He worked on the public dental hospital. The patient, she was one of his case. The patient already did at that time did the orthodontist for 1 year, but suddenly the patient got swelling on this area, and we can see some sinus here with spas, and the tooth was mobile, was very mobile. And orthodontist did splinting. It's a very ugly but quite effective splinting on this patient. And the patient, he referred patient to me. I took an periapical X-ray. I say, oh, there's no bone on the mesial side of the 1-1. And after the oral hygiene instruction, I wait 2 weeks. I think patient could do a very good job on clean the tooth, and I did the surgery. Once I open up, it's one wall defect, and it's the bone loss up to the apex of the roots. And I saw I think it's some temporary filling material on the root. So I removed that and filled with GI at that time, and I cleaned up the defect. At that time, the doctor, the orthodontist told me it's around M2, there is mobility 2, degree 2, it's quite mobile. So I used the alternative bone graft from the tuberosity, and at that time I used the PRF to cover that. And because I took the bone graft from the plato, so at that time I just took 2 pieces of the soft tissue graft as well to enhance the thickness of the soft tissue. And after stitching, it looks okay. And it is 6 months later. The healing is uneventful. And luckily, or wisely, I put a physician pin, it's a tack pin, on that area, on here. And I have reason to re-entry the surgical area. So I raised up a little flap. The tack pin was there, and I removed that. And at that time, I can see the regeneration of the alveolar bone. It looks quite good. And then I just asked the orthodontist to remove the splinting, and the tooth was very firm, it's not loose at all. And the surgery was quite cheap because the orthodontist is a worked in a public hospital, and it's some mistake, I guess, he made. So he asked me for a privilege for reducing the treatment fee. So I charged quite nicely to the patient. I charged only maybe 7,000 for that. And I didn't use any biomaterial for this patient. It also saved a lot of money. And patient didn't see me, and it is the latest clinical photo took by the orthodontist. It was 5 years after the surgery. It still remains very stable. It's limited. It's only 2 millimeter propping depth. But at that time, he didn't take the periapical X-ray, and this one is also with quite severely compromised periodontal case. We see very severe bone loss afterwards. It's a 10 millimeter pocket with separation, and after the simple gentle debridement, I try to save more soft tissue for this patient, so I do very gentle debridement. And after 2 weeks, I think the patient can brush well, and I did surgery. And at that time, I found there is no bone on the plateau side, and there is a deficiency and fenestration on the buccal side as well. The tooth was mobility 2 at that time. And I did bios and bioguide to fill the bony defect. And I close the flap by VIP flap. I close the flap here by VIP flap. VIP flap. You know VIP. So it's a pedicle flap. They have enough blood supply. So the surgical site healed very good, and it's after 7 years. The tooth was very firm, and there's no popping depth, pocket depth more than 3 millimeter, and we see the bone regeneration around the roots. And that one is also quite funny. It's a lady who has a very mobile anterior tooth, 2-1. And also we see the buccally tilted of the 2-1, and the looking is very strange here. So after the gentle debridement, I confirm the patient can do a great job on oral hygiene instruction, oral hygiene practice. I did surgery. I changed these 2 crowns to splinting temporary crown, and after I opened the flap, I found there was no bone surround the root. So only the tip of the root have minimum bone, a minimum attachment. So during the surgery, I cut the splinting, and I changed the position of the root to the better 3D position, and I re-cement here. I put some Lycol composite here to change the position of the root, and I do alternate bone graft and covered with soft tissue and the suture, and afterwards it looks much better. At least the looking looks much better. And then the bone is maybe a little more compared to before, but it will disappear later. And there is no pocket more than 4 millimeter. It's okay. Once the situation was getting stable, I delivered the final prosthesis with splinting crown. I seldom do splinting crown, but for this patient I have to do splinting crown because this one is a little bit loose, but no pocket. So it's 2 years later. We already see the bone level change a little bit. That is okay. No pocket. And it's 4 years later. you see the maturation of the gum is looks even nicer than before. And also no pocket more than 3 millimeter. Deepest is a 3 millimeter something, and the bone stays there. But if I cut off the bridge, I think this one is a little bit loose as well. It's unchanged. But the patient was very happy about the condition. If we suppose we extracted the tooth, what can we do? The implant is not that easy to place as well. So it's better to keep this condition, I guess. And that one is very interesting. It's a periendal lesion for the 2 central incisor. Even after non-surgical periodontal therapy, it still have pocket more than 10 millimeter. So after I raise the flap, I see I have 2 big holes, and it took me 2 hours to clean up. I thought I already done my best for cleaning. Afterwards, I put some bone graftings and put the non-resorbable membrane to cover the wound. And it was 4 months later when I removed the non-resorbable membrane. The bone regeneration is quite okay. Then I delivered the final prosthesis for this patient. And you see the change of the periapical. The bone looks quite okay. After 5 years, the patient bite something really hard. And he lost the right central incisor, and you see the lateral one, the veneer is also fractured. So I have to put 1 implant on one. So after I put the implant, the patient is okay again. Now it's 8 years, we can still see the 2-1 is quite nice. It's very firm, no pocket, no stability, no mobility. It's quite nice. So actually, we can do a lot on parallel stuff, rather than just simply extract the tooth. Extract the tooth, probably the most simple things for us to do. And for this patient, the 1-2 is very mobile at the time, but the patient want to save it, and 1 is missing with a huge bony defect. So I put the implant, at the same time I do the simultaneous bone grafting. And afterwards, 1-2 is become very firm, and I do a prosthesis. After 9 years, it remains stable, no problem. And for this one is the patient with vertical augmentation, vertical defect. It's 8 millimeter vertical defect, and the 2-2 is very mobile. At that time, we can see there is a periendal lesion. There's only have some bone here. So after the vertical augmentation with titanium mesh and valves, we can achieve some bone. Then I put the implant, and it was 1 year after I delivered the final crown. And after 9 years, you see some recession of the peri-implant mucosa, also in the natural tooth, but the bones around the implant and the natural tooth is good. So I keep the 2-2. And that one is another case, is a lateral groove, it's an anatomical factor. For also another orthodontist, he referred to me. So when I opened the flap, I was shocked. There's no attachment almost. So, but the patient wants to keep the tooth. We discussed during the surgery, and I remove the grooves and fill with the GI. and do the GTR on these tools. And it's sutured. And afterwards, I have to split the tools because it became really mobile. And after 1 year, because of the COVID-19 pandemic, the patient came back. Afterwards, the patient continued to do the orthodontic treatment. Now, just mid of this month, the patient removes alignment. So I didn't see her now, but my assistant says the tooth is fine. It's not mobile. So I want to see her personally as quick as possible. And that one is a really tricky one. The patient have a very severe periodontal disease. The 3, 7 have to be removed because there's no bone at all. But 6, we can see the bone loss to the apex of the root, distal root. And patients strongly have strong desire to keep the tooth, so I said I will try. And I keep this one. And at that time, when I use keratinized, that one can cross the defect. So there's no bone on the apex. And I just put some collagen in the area. And after half a year, and I do a splinting because this one is really loose at that time. Was really loose at that time. I wait for 6 months, and when I saw the patient, I found the splinting was broken, and the tooth was formed. It was okay, the tooth. And also, before there's no bone, but after 6 months, there's some bone grows back on the apex of the distal root. It's very, very strange to me. And at that time, I do the 3-7 implant, and I do the bone grafting on the furcation area of the 3-6. You see do some grafting, and here is the implant. And after another 6 months, there is no pocket on the furcation area, but you still can see some resolucency on the furcation area. And it's 2 years after the final prosthesis, we can see the completely closure of the furcation. The bone grows in. I don't know why, but I think it's a very weird case. And there's no pocket on this area as well. And the final one, the Johnson most like that one. The patient with desperate situation of the anterior tooth. The exact is awful. The patient received multiple root debridement on this area. Then the gene will recede a lot. And at that time, I did a bone graft, GTR. I used some allo graft and alternative graft mixed together to build up the bone and cover with the CTG. And afterwards, after healing, 6 months healing, it become a little bit better, but it's still not enough. So I have to do additional soft tissue graft. For this patient, I did a tunneling technique with autonomous. The graft was took from the tuberosity, and I used some color matrix to fill up the space. And afterwards, the healing is good. It seems much better. And surprisingly, the one tooth seems not that symmetry to the contralateral tutu. So I have done a mini graft to cover the exposure route. And after a couple of months, it looks good. It looks almost symmetry, and I've done final prosthesis on that one, and it looks okay. But it's very short term. Okay, so I had to wait longer to see the result, long-term results. So that case is similar to this one. So the final result is also acceptable, and the GTR with the bone growth in the interdental area. Okay, so we have actually the pioneer. We have pioneers to discover this kind of regenerative approach. They already have 20 years of results that shows the survival of the saving tools for 20 years is 72%. It's quite nice. And also the cost for the natural tools is lower than the implant. And systematic reviews shows the long term of the survival rate and the complication rate of the implant and natural tools is quite similar. And the cost is cheaper for the natural tools. So this is my last page. So the patient was referred by colleagues. Why? Because he went to the stomatological hospital in Beijing. The periodontist said the tooth cannot be saved, the teeth cannot be saved. You should wait and remove them all later. Because the tooth is all mobile with 1 to 2 degree of mobility. And I did the periodontal treatment, and my colleague did the orthodontic treatment. The patient looks okay. Now it's already 5 years. We just extract the wisdom tooth. We kept all of the tooth, all of the teeth. And another one, I took the picture from the internet with quite nice supporting bone. The doctor removed all the teeth and put the implants. So I think it's a demon dentist. Yeah. So don't forget this is our commitment to the patient to keep the natural tooth. No, sorry. So to save or not to save. That is the question. So we have to think about the question. Thank you for listening. Thank you for overtime. Sorry.
Thank you, Dr. Van. Dr. Van is a clinician that always chasing for the excellence for the patient. Now is our Q&A session. Is there any question from the audience? Anyone?
Nice. No questions. Yeah. Oh, no.
Thank you for a very nice lecture. In your bone graft, did you attempt to use this endocrine just to facilitate bone regeneration?
Use what? Sorry?
Endocrine.
I have no endocrine in mainland China. Sorry.
Oh.
We don't have, but in next year we will have, but not now.
So if endocrine were available in China, would you attempt to use it?
Definitely.
Okay.
Definitely. It's a completely different mechanism for the regeneration. So I definitely will use that.
Okay, thank you.
Okay, thank you.
Is there any more question? Okay, okay. Just one more question.
Oh. Oh no.
Thank you, Dr. Wan. Very nice lecture, amazing. My question is, collagen matrix you use, do you have any requirement like thickness or, for example, thickness or what kind of collagen matrix you will recommend?
Oh no, because that's well, it's not the commercial lecture, so I couldn't recommend any brand of the matrix. Yeah, you'll probably go outside take a look. Yeah, and but the Seeker is better, I think. They have the better 3D structure for the cell to growth.
Okay, we have one more question. Okay.
Dr. Ben, thank you for your lecture. The results of the are very impressive of your cases. But I want to ask if for the most latest case that you show for the periodontal defect, actually from your experience, what is the percentage that some cases may fail after you put the bone graft around the periodontal the affected teeth, and what is the success rate of such cases?
You mean the most difficult situation, or
when you put
average?
the bone graft on the periodontal defect of the natural teeth?
All kinds of. You mean? I mean the defect construction is all kinds of construction, or like 1 walls, 2 or 3 walls. Vacation 1, 2, 3, 4.
Yeah, maybe generally, what is the
Generally it's quite high. It's definitely more than 95%.
Oh,
I think. But for the supercrestal defect, it's really difficult, and also the crater defect and the class 4 vacation defect, especially on the upper molar. It's I won't challenge that. No, thank you. Okay.
Okay, may we invite Dr. Wan to remain on the stage? We would like to present a certificate and souvenir to him to express our appreciation for his presentation tonight. Please support.